now we'll have questions, starting with me. Obviously, I can't reach everyone, so I'm going to direct my question. I would try to get in three questions about primary care, Medicaid, and DISH, if I could. And I'm going to start with Dr. Epperly on the primary care promotion issue. We've obviously heard a lot of testimony about the primary care shortage. We've heard that action on a single front is not enough, but that concerted action across the health system is going to be required. And the discussion draft reflects these calls for action. It proposes major investments, and I'll list first in increasing the rate paid by Medicaid for primary care services. Second, the primary care workforce, including increases for the National Health Service Corps and scholarship and loan programs. Third, payment increases in Medicare and the public option for primary care practitioners, including an immediate 5% increase in payments and high growth allowances under a reformed physician fee schedule. Fourth, an additional payment incentive for primary care physicians in health profession shortage areas. And finally, an expansion of medical home payments and added flexibility for that model of care. The draft also proposes a reform to graduate medical education programs funded by Medicare and Medicaid. Two questions. First, will these proposals help to reverse the decline in interest in primary care among medical students? Dr. Epperly.
Absolutely.
Okay.
Did you want me to expand on that?
Yeah, well, let me give you the second one, and then you can talk. The second was, will the rate increases proposed for primary care services in Medicaid and Medicare help to address problems with access we've seen in those programs over the past several years? So generally, will you reverse the decline among medical students? And secondly, what will it do for access to Medicaid and Medicare?
Thank you, Mr. Pallone. I would say to you that the return to a primary care-based system in this country is essential. It's at the, if you will, it's foundational to building the healthcare system of our future. To get primary care physicians back into a position where they can integrate and coordinate care, lower costs, and increase quality, we must do that. Right now, primary care is in crisis. A lot of that has to do with the dysfunctional payment system. Primary care practices are barely making it in regards to their margins. So what we have to do in terms of the reform measures is, number one, make this viable financially for physicians to choose primary care.
But tell me whether you think these proposals that are in our draft discussion will accomplish that. Will we get more medical students to go into primary care, and what will it mean for access to Medicaid and Medicare, specifically with this proposal before us?
Right. So medical students now are opting not to choose primary care because they can see that incomes can be 3 to 5 times higher if they choose subspecialty. So the payment reform will help narrow that gap and disparity so that they choose more to do primary care. The derivative effect of that is that workforce will then be enhanced, access then increases. What we must do in the system is not only cover people, but we've got to have the right types of physicians in the right communities to see them. So it's kind of multifaceted, multi-layered. We've got to fix payment, which will increase workforce. Workforce will enhance access. That's how it's all linked. What it saves America is cost in the long run, increases affordability and access as a derivative.
Do you believe that this discussion draft will accomplish that?
Yes.
Okay.
Yeah.
Now let me just ask my Medicaid and DISH question of Dr. Gabo, if I can. Can you talk to us on Medicaid? What will it mean to have Medicaid covering up to 133% of the federal poverty level, having subsidies that help people access health care up to 400%, and to have individuals' response to encourage all else to make sure that their dependents have health insurance? So basically, you know, the increase to the poverty level to eligibility for Medicaid, the subsidy in the health marketplace, and the individual mandate. That's a lot.
Yes. Well, clearly,
1 minute.
Anything that expands coverage, particularly for low-income, vulnerable people, will reduce our $360 million of uninsured care. But as it relates to Medicaid disproportionate share payment, I think the timing is important. We would like to make sure that we see that the patients actually who are eligible get it rolled, and that they are covered, and that our uninsured costs go down. before there's any change in disproportionate share payments. So we applaud your version of the draft bill regarding DISH. We know that many patients who we hope to get enrolled are the most difficult to enroll. For example, the homeless, for whom we did over $100 million of care last year, the chronically mentally ill, illiteracy. These patients have been difficult to enroll in Medicaid. So I think expanding Medicaid is terrific, but I don't know that immediately it will reduce our need for other coverage. Ultimately, it should, and I think we've seen in Massachusetts that a reduction of DISH at the front end has had a negative effect on the two principal safety net institutions. So I think the expansion of coverage that you are planning will reduce the amount of uninsured care over time, and we need to deal with that then sequentially as regards DISH.
Thank you. Mr. Deal.
Thank you. I'm going to ask for a yes or no answer from a couple of you on this first question. We just heard the preceding panel member, who is chairman of MedPAC, say that he felt that Medicare reimbursements were adequate. And I would ask if you concur with that. Dr. Williamson?
No.
Dr. Ulrich?
No.
Dr. Wright?
Nope.
Dr. Epperly, I'm going to ask you that question in the context of the current reimbursements under Medicare, not counting the bonuses that are proposed in this legislation. Do you consider the current Medicare reimbursements to be adequate?
No, sir, I don't.
Have you, Dr. Epperly, as a result of that inadequacy, seen many of the members of your organization not take Medicare patients?
Yes, sir, I have.
All right. Dr. Williamson, first of all, let me acknowledge that he's the president of my Georgia Medical Association, and I'm pleased to have him here. I made those statements yesterday in your absence as we began these hearings yesterday. Dr. Williamson, let me ask you what you think the impact would be for the public option plan to adopt the Medicare reimbursement plan as its model. How would that impact the delivery of health care under the public option plan, and also as it then migrates, in my opinion, to the private insurance market?
I think it would have a very adverse impact on access for patients and on the delivery of quality medical care. Right now, access for Medicare patients, I think, is really a house of cards. A lot of doctors are there simply by inertia. And surveys that have been done in Georgia amongst practicing physicians show that a large percentage of doctors plan on dropping Medicare in the near future. And I think that that is just basically a train coming down the track. And I think any system that is modeled on that premise is really going to fail in the short run, not the long run.
The doctor-patient relationship has been really the cornerstone of the importance of our healthcare delivery system that makes it work. I would ask you, Dr. Williamson, in light of this draft legislation, in particular the comparative effectiveness portion of it, how do you see that potentially impacting that doctor-patient relationship?
I think it's going to push us farther and farther away from it, which is really, I think, the opposite direction that we need to be going. I have serious concerns that bundling payments is going to drive a wedge between patients and their physicians. I know that in some clinics that we've looked at as examples, that type of environment works, but those are rare, and I think they're different than the general practice of medicine across the country. And they have a different patient population in some cases. I have grave concerns about comparative effectiveness as well. I think this would essentially give the federal government the ability to practice medicine. And I know that's a strong statement, but let me say this. Scientific research is not new. It's always been done, and it's always been the basis of medical learning and medical treatment. But the art of medicine is taking this science, these large studies, and applying it to an individual patient. When you try to treat the individual from the 30,000-foot level, it's very difficult. And I'm afraid that this would drastically diminish our choice of options for our patients. I can tell you that I'm well aware as a neurologist of the importance of the last 20 years in pharmaceutical research. I have a lot of options for my patients now that weren't available before. And some of these things are found quite by accident. and we take them and we apply them, and they may be off-label drugs and that sort of thing. And they may even be therapies that have not been shown to work in large randomized controlled trials that take many years and millions of dollars to accomplish. And if we're limited by that, we're going to have a lot of therapies taken off the table for our patients. And I'll also tell you that I think that it's a bit of a conflict of interest to have the government deciding what is valuable to patients because they're serving as the largest payer. I think that the physician and the patient ought to be able to decide in the context of private contracting what is value and what is appropriate care.
Thank you. Mr. Roberts, you have alluded to the issue with AMP. As you know, earlier this year I introduced an amendment that I think was more appropriately dealing with this federal upper limit for reimbursement of going to 300% of the volume weighted average, and also included a minimum prescribing fee for pharmacists, or dispensing fee, I should say, for pharmacists. Which of those options do you prefer? What I offered earlier this year versus what's in this bill?
Well, I think, Congressman Deal, that the challenge that we have is that we really don't know what this benchmark is. There have been some changes made in the current version that redefines the benchmark in a way that will make it much better than what it was. But the reality of what you are proposing and having a minimum dispensing fee, I think, is absolutely critical. The challenge that we have is that, the benchmark is just meant to get us to break even on the cost of the product. But the reality is the states set the dispensing fees, and the dispensing fees are all over the place from one state to another. And so unless the federal government take some action to say, that our costs of dispensing and a small profit are available to the pharmacy, it's going to be very difficult to have pharmacies remain viable and still stay in the medication.
Mr. Chairman, I take that as an endorsement of my approach, and I will yield back.
Thank you. Our Vice Chair, Ms. Capps.
Thank you, Mr. Chairman. And I want to thank again all of the panelists for appearing today. It was a very interesting presentation that each of you made, a lot of linking, which I think is really important for us to have as part of this discussion. Of course, Dr. White, I want to single you out and thank you for being here today to represent the voice of America's nurses, who are so important every day in delivery of health care, but also in understanding what this crisis is all about. I was very pleased to hear that the American Nurses Association has endorsed a public plan option. I also support this option and the one that we are developing in this legislation, and want to hear your perspective a bit more as a nurse on why this is so essential, because it is one of the crucial parts of the choice that people are going to make, whether or not they support this reform legislation. Nurses, I'll ask you to do it within this framework. I often speak about the role that nurses have, not only as providers of health care and delivering service, but we're also patient advocates. And would you talk about maybe the reason you endorsed as ANA the public plan option, and why you feel it is best for patients, and perhaps are encouraging patients to advocate for this as well as the choice, to have this choice be made available?
Thank you, Ms. Capps. I'm happy to answer that question because I do think it's extremely important. The American Nurses Association endorsing the public option plan because, as you said, our role in direct care, we're there 24/7, 24 hours a day, 7 days a week, 365. If depending on how long a patient is in there, we don't like to think it's that long, but we see patients and families and how they're dealing with the catastrophic impact of illness, whether it's an episodic, a single acute that affects the patient and their family, or whether it's a long-term kind of chronic condition that includes many admissions or many returns, and not being able to have a choice of insurance, I think, is key. And unfortunately, we've seen employer plans rising, the cost of those to patients rising greater than wages over the last several years. And so patients are looking for other ways of paying for their health care insurance, and sometimes those plans may not be exactly what they think they are, or they may have surprises. So certainly a public plan that includes some type of defined or essential benefit package that the patient, the family, could be sure will be there when they need it, I think is extremely important.
Let me follow this by another aspect of our reform legislation. One of the ways, Dr. Epperling mentioned this, but he wasn't the only one on the panel, which was interesting, who is stressing now primary care as one of the ways we can lower health costs, and the ways that he discussed on how we can improve our primary care workforce. But there are many advanced practice nurses, nurse practitioners, and others who can and do serve as primary care providers. And this bill ensures that nurse practitioners can be the lead providers in medical home models and increases reimbursements, for example, for certified nurse midwives. Can you discuss this a little bit? You mentioned one bill that I've co-authored on nurse-managed clinics, but that's not the only avenue. And you might mention a few others
Sure.
for the record.
Absolutely. Obviously, the nurse-managed clinics is an extremely important way for many vulnerable populations, inner-city, rural areas that get primary care and other follow-up care in those areas. And as far as nurse practitioners, as our advanced practice nurses functioning within the primary care medical home and being able to lead those teams. We've seen in the demonstration projects throughout the country that nurse practitioners have been paneled. They do function to their scope of practice in the different states and the different demonstration projects, and have been able to lead their panel of patients and provide that primary care. I think it's extremely important when we're talking about the shortage of primary care that all providers be able to be used to the fullest extent of their scope that they can provide the care.
Thank you very much. I'll yield back.
The gentleman from Indiana, Mr. Boyer.
The challenge we have with a panel this large is to try to get our questions in. So if you can take out a pen and pad, I'm going to rip through some questions. It won't apply to all of you. First, I'm going to go to Mr. Yarwood. When you stated the provisions in the draft bill would cut Medicare reimbursement rates to skilled nursing facilities by $1.05 billion in FY 2010 alone, and ultimately $18 billion from skilled nursing care over 10 years, I'd like to know whether you've calculated the number of jobs that would be lost due to these cuts. Next question I have would go to Dr. Ulrich. The draft bill provides that physicians who treat both Medicare and the public plan patients would receive Medicare plus 5% for treating their public plan, really the government plan, patients for the first 3 years. What is the, quote, magic number, end quote, regarding the percent of Medicare that it would take to keep you whole? Is it Medicare plus 10, plus 12, plus 13, plus 14? The other question I have for Blue Cross Blue Shield, what are the advantages that the government plan would have over the private insurers? What about state premium taxes, state solvency regulations, state benefit mandate requirements? And the last question I have, I'm going to go right down the line with all of you. Medical liability reform, should it be medical liability reform that restricts excess compensatory awards, limits on punitive damages, and attorney fees, should this be part of the public plan option? Let's go right down the line. Dr. Epperly?
Yes, we believe that.
Dr. Williamson?
Absolutely.
Dr. Ulrich?
Yes.
Dr. Wright?
Yes.
Dr. White?
Yes. Yes.
Yes.
We have FTCA coverage, so I can't really comment.
All right, one equivocator.
Yes.
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 All right, all but one, except Mr. Hawkins, testified in the affirmative that it should be included. The other is, would everyone on this panel agree that individual liberty is a cornerstone of our society as an unalienable right? Would everyone on this panel agree? Okay. Mr. Hawkins, you in? He's in. All right. Awesome. Now, an individual right. If in this scheme we're moving people into the government plan, what about an individual's right to contract with a physician of their choice? Should an individual in America have the right to contract with an individual doctor of their choice? Yes or no? Dr. Epperly?
Yes.
Oh, let me go down. Without penalty from their government. Dr. Epperly?
Yes.
Dr.
Yes.
Williamson?
Yes.
Yes.
Individual provider, yes.
Atta girl.
Yes.
With their own money, yes.
Attaboy.
Yes.
Oh, we're on a roll. Now, does everyone agree that in the capital economic system that we have, even though we may have a public option plan, that the marketplace should be able to create some type of an instrument that would be a supplement, a potential medical insurance supplement plan? Should that be some type of an option that the marketplace could create? Dr. Epperly?
Yes.
Yes. Yes.
Yes.
No.
Well,
I'm not sure.
okay. Dr. White's an unsure.
No.
A no.
I'm not sure I understand.
I'm not sure.
Sure, I do either.
Two, I'm not.
I'm a number 3, not sure.
Well, we're hoping that there is no public plan.
Pardon?
We're hopeful there will be no public plan in the program. Yeah.
All right. But if there's a public plan, should individuals in the marketplace have an option, be able to create supplemental coverage?
Yes.
Yes?
Like Medicare today.
All right. Thank you. Now I'll rest and allow those individuals to answer the questions that I'd asked.
The answer is Medicare plus 100, and I can expound as to why if you'd prefer. I think in my testimony I cited the fact that we currently in Wisconsin, from the private sector, get anywhere from 180 to 280% of Medicare in payment. Medicine is changing, and this is what's really interesting, is that we've gone from kind of being a cottage industry to now much more high-tech. Our costs are very different than what Medicare allocates to us now. We now employ, for example, systems engineers. Why? Trying to understand efficiency of workflow. We also, in our clinic and others as well, employ many people in information technology. We've developed our own electronic medical record. We have close to 350 employees now, software engineers, et cetera. Our cost structure has shifted dramatically from what the traditional concept of what medical practice is, a nurse practitioner, physician, a nurse, a technician, et cetera. And so the costs keep changing. The other thing I would ask this committee to keep in mind is that medicine as an entity is an ever-evolving one, in the sense that we've come from guessing at what causes disease
Ulrich,
a couple of
could
centuries
you,
ago. Yes.
We're way over time. Could
Okay.
you wrap up your response, please?
I will just stop there if my initial answer satisfied you.
Mr. Yarwood, do you have an answer?
30,000 jobs
30,000 jobs
over 10 years, yes.
would be lost.
Yes.
Thank you. The gentleman's time has expired. The chair now recognizes Ms. Castor for 5 minutes.
Thank you, Madam Chair, very much. And I'd like to return to the workforce issues. This bill rightfully targets workforce incentives because we must bolster the primary care workforce especially. 50 years ago, half of the doctors in America practiced family medicine and pediatrics. Today, 63% are specialists and only 37% are family doctors. And it's those family doctors and the nurses on the front lines and the pediatricians that really help us contain costs over time. I do not know what I would do if I did not have the ability to call the nurse in my daughter's pediatrician's office and ask a question. And they've had a consistent medical home over time, and yet millions of American families do not have that type of medical home and relationship with their primary care providers. So I think our bill does take important steps to bolster primary care workforce, but one place that I think it falls short, and I'd be very interested in your opinions, is that we are not increasing the residency slots for our medical school graduates, these doctors in training. The discussion draft provides a redistribution of unused residency slots to emphasize primary care, which is a good first step. Because we're going to hopefully send them to community health centers and other hospitals in need and other communities in need. But we've got to enact the second step, the complementary step, to even out the residency slots because, for example, in my home state of Florida, the fourth largest state in the country, we rank 44th in the number of residency slots. And most folks do not understand that those slots are governed by an old, outdated, arbitrary formula that assigned a distribution many years ago and has not changed, even though the population of the country has shifted. So I'd like to know, do you agree? Dr. Epperly, you might be the one most in tune, but I think many of you would have an opinion on that. Do you agree we need to alter the residency in toto? And then are there sections in the bill related to scholarships and loan repayments, are they adequate? Are we doing enough?
Yes, ma'am. Can I expand for just a second?
Yes.
In my day job, I'm a residency program director of a family medicine program in Boise, Idaho. And you're right on. In fact, the workforce numbers are about 70-30 subspecialists to generalists. We must increase residency training, especially for primary care. Again, what are we trying to build? What system are we after? We think there should be some regulation of what kind of physicians medical schools are producing. It needs to meet community needs, and so we're in agreement with some sort of workforce policy center to kind of take a look at this and what it is we're trying to accomplish. Totally agree with you in terms of scholarships and loan repayment. Scholarships on the front end will be more effective than loan repayment on the back end because it helps shape the types of physicians you're trying to train.
Anyone else want to comment quickly? Okay. Then I'll move on. Ms. Fox, thank you so much. It's great to hear that Blue Cross is supportive of health care reform. What I wanted to share with you, I had a great meeting last week with the Florida CEO, President and CEO of Blue Cross, and you all are a very important provider in the state of Florida. You have about 32% of the market share in the state of Florida. Let's see, I wrote it down, 4 million Floridians are enrolled in Blue Cross and depend on you all every day. It was interesting that the CEO from Florida had a slightly different take and spoke much more favorably of the public option because while Blue Cross in Florida has 30% of the market share and over 4 million folks enrolled, you know, in Florida we have 5.8 million people who do not have access to health insurance because it is so expensive. And I think that in the discussion we had, he just saw it as an opportunity that you all are so effective that you wouldn't have any trouble competing against a startup public option. And I thought we had a great discussion and exchange, and I was heartened to hear that maybe it's not maybe while Big Blue Cross has a certain position, the folks on the ground in my state are not daunted by the challenge ahead.
Well, I would respond that I think people are looking at, can you create a level playing field? And I think it's very difficult to imagine how you can. And when I look at the House draft bill, I just see huge advantages for the government plan, ranging from big advantages in the payment levels to lawsuits, to covering the government plan would cover a lot fewer benefits than private plans would be required to do. There's just a long list. For example, if the government plan didn't estimate their premiums correctly, would the government step in and subsidize
But where do these almost 6 million residents of my state go now? How do they, we can't afford, America can't pay for all of them to go into subsidized Medicaid. We've got to provide a level playing field and a real opportunity for them to access affordable care.
Well, we agree. We need to cover everyone, and we're recommending covering everyone in poverty under Medicaid, and then above that, having subsidies, as you do in your bill, for private insurance to help people afford coverage. We think that is absolutely critical. And you know, I've been doing healthcare issues for over 25 years, and it used to be that everybody believed that if you have individual mandate, employer mandate, alliances, insurance reforms, that really would cover everyone. It's only been the past year people have talked about a public plan. We think it's totally unnecessary and very problematic.
Thank you. The gentlelady's time has expired. I now recognize Mr. Burgess for 5 minutes.
Thank you, Madam Chairman. And Ms. Fox, let's continue on that, and maybe if I could, I think Mr. Bouyer was asking a question, or you were answering a question when time ran out, and maybe we could just get the answer to the question that Mr. Bouyer posed about the advantages that a public plan rather would have over private insurance in premium taxes, state solvency regulations, and state benefit mandates.
Yes, I mean, private plans have to pay a wide range of premium taxes, assessments, federal taxes. The government would be exempt from that. We've actually prepared a little chart that we'd love to submit that actually walks through what are the rules private plans have to abide by.
If you'll suspend for a moment, I'd ask unanimous consent that that chart be made available to the members and made part of the record.
And raises questions, would the public plan abide by that? And when we look at the draft bill, we see just a huge unlevel playing field where the government would have so many advantages that you could see why people will estimate that millions of people will leave private coverage that they like today and go into the public plan.
Okay, great. I appreciate that answer very much. Dr. Ehrlich, let me just address you for a second. And I really appreciate, well, I appreciate all of you being here. I know that many of you are taking time off of your private individual practices, and it's with great expense and inconvenience to your families, and we've had a long day and appreciate your willingness to be part of the panel here. The physician group practice demonstration project that you referenced at your clinic, I'm somewhat familiar with that. I think that does hold a lot of promise. In fact, you may have heard me question Mr. Hackbarth from the MedPAC about the feasibility of using the Federal Tort Claims Act for Medicare providers under a physician group practice model, under the accountable care model. If you comport with all of the requirements, disease management, care coordination, the IT, the e-prescribing, if you do all of those things, getting some relief from liability under the Federal Tort Claims Act. Do you think that's is that a reasonable thing to look at?
Absolutely.
And thank you, and appreciate your brevity. Let me ask you this, since we're in agreement. Yeah, one of the things about the physician group practice demonstration project was you were going to actually benefit financially by doing things better, faster, cheaper, smarter. And in fact, there's some great lessons for us that have come out of those management techniques. But there's a barrier to entry, and do you think the bar to that has been set too high? You've got to make a lot of initial investment when you get into that, and then your return for your doctors, for the people in your practice, is a little slow in coming. Is that not correct?
Dr. Burgess, you show keen insight here into this, and if I can just take a second to explain this. As part of the group demonstration project, what we're finding is that it's not just trying to strive for quality outcomes. There are operational changes that you need to make in how you deliver care. For example, we have consolidated all of our anticoagulation patients into one entity. Rather than being in each physician's practice, we now share that coordinated care under one entity. And what we found is that our capacity to have bleeding times, for example, are much better, be within the therapeutic range. We also are consolidating care of congestive heart failure rather than being in a particular individual physician's office, whether it be a cardiologist or a primary care physician, into a congestive heart failure clinic, where physicians craft the criteria we want. Our nurses watch those. We are proactive in working with the patients. The problem with doing all that is that no one pays us, to undertake those operational changes at first. What we're hoping, and why we partnered with the federal government through the CMS PGP project, is that we're trying to prove that, yes, by undertaking these, ultimately there are cost savings. Lastly, I would just make the point that we're just beginning the process of understanding the cost of care in chronic illness over time. We understand what the costs are to provide care on an individual visit, but not over time yet.
Yeah, one of the things that concerns me about our approach to things and what little I know of the great successes you've shown, for example, like bringing a hospitalized CHF patient back to the doctor's office within 5 days, not just you make an appointment in 2 weeks, you get that patient back to the office in 5 days, and you really reduce the rehospitalization rate significantly. And yet you've got CMS now writing a rule that says, well, if that's the case and you can do that, we're just going to pay for one hospitalization every 30 days, and that'll cut our costs down. It's an absolutely backward way of looking at what the data that you all are generating, and instead of building on your successes, in fact, we're going to make things punitive then for Dr. Williamson in Georgia, who may have an entirely different type of practice.
Correct.
And again, that's one of the things that concerns me about this. Do you have a concept? You mentioned about the rate of reimbursement on the Medicare side. What would that multiplier have to be in your accountable care organization or physician group practice? What would that Medicare multiplier have to be in a public plan?
We would say Medicare plus 100.
Medicare plus 100%?
Yes.
So double what the Medicare rates
exactly.
are?
Yep.
That's a fairly significant.
That is a significant, but it's also a realistic significantly high.
And do you have data to back that up that you could share with the committee?
I would be happy to provide information to you in written form relative to that, yes.
That'd be tremendous. So, Dr. Williamson, in words of one syllable, we heard Glenn Heckbarth say that no doctors are not seeing Medicare patients now because of the reimbursement rate. Is that your sense? Do you think doctors are restricting their practice because of the reimbursement rates in Medicare?
Yes.
Thank you.
Thank you. The gentleman's time has expired. I now recognize myself for 5 minutes. And let me just welcome everyone. It's great to have such a diverse panel of witnesses here, and we thank you for all of the good work that all of you have been doing in a dysfunctional system that really doesn't always give you the kind of support that you need. And I want to particularly welcome Dr. Epperly, President of the American Academy of Family Physicians. And I want to direct my first question to you, Dr. Epperly. In meetings, for example, with the Tri-Caucus, we're on record as supporting a public plan, and I do support a public plan, but also a public plan that is linked to Medicare. I have raised concerns about that in our meetings, and I'd like you to elaborate on your concerns about linking the public plan to Medicare.
Yes, ma'am. Thank you. First, we're definitely in support of a public plan option, but we do have a couple caveats. One of them is linked to Medicare, just as you're saying. We recognize there's going to be a huge infrastructure cost in getting this thing up and running. So our position is that it can be the Medicare rate for the first 2 years, but with a date certain then to elevate that. More of just Medicare rates won't cut it for the physicians across America. It's already a problem.
Right.
So, but we recognize that there's going to be a transition period. We recognize that flexibility. So what we would say is, yes, we're in favor of a public plan. Medicare rates could be what it would be aimed at for the first 2 years, but by date certain, that has to elevate.
Thank you. And I guess I can't ask everyone this question. So Dr. Epperly, Dr. Gabow, and Mr. Hawkins, you've heard reference to bundling of payments by Mr. Hackbarth of MedPAC, and I wanted to know if you are in support of the proposal to bundle payments to providers. Dr. Epperly?
Yes, ma'am. We're in favor of bundling in terms of a team approach. We do have concerns that we'd want to make sure that primary care and the patient-centered medical home as a very important part of that bundling was not denigrated nor belittled into its importance. For instance, with the heart failure example, we're talking about heart failure patients and readmissions. Let's prevent it from in the first place. So with a bundling model which looks at already this has occurred, it's in the hospital, how do we pay for this? Why don't we take a better approach and look at what it takes to prevent that in the first place? So therefore, the patient-centered medical home primary care is critical in that. Bundling could be a very interesting option if the primary care physician has reincorporated that into that in a big way.
Dr. Gabo?
As an integrated system that employs physicians, we favor moving away from fee-for-service to a more global payment. And we would favor the ultimate bundle, capitation, and think that capitation or more global bundling would have less administrative costs than if you bundle small things. So I would encourage it to be global, but we favor it given an big integrated system.
Congressman or Mr.
Would it affect,
Madam Chair,
would it affect community health centers?
really, there are some important points to make here. On today's panel, we're very fortunate to be joined by Dr. Epperly, who runs a family medicine residency program, Dr. Ulrich, who runs the Marshfield Clinic, and Dr. Gabo, who runs Denver Health. Unique, and especially with the last two, fully integrated healthcare systems. What may not be known generally, but should be, is that all three are community health centers, or have community health centers embedded in them. As such, two examples, Denver Health and Marshfield Clinic, are good examples of integrated health systems that include community health centers. But I'm sure, as Dr. Gabo and Dr. Ulrich would agree, the primary care component, the very issue that Dr. Epperly expressed concern, appropriate concern over, is identified, and I'm not going to say separate, but it is able to function on a sort of co-equal basis with the specialty and inpatient care components of their institutions. To the extent that that's done, I think that's what Dr. Epperly was relating to when he said primary care needs to be recognized and appropriately integrated. We would agree. The notion of integrated care systems, accountable care organizations, and the like, and rewarding results is something that we all absolutely support. What should not be lost, however, in the integration of care, the vertical integration of care across primary, secondary, tertiary care, is the small ambulatory care practice, be it independent practice, private practice, physicians, health centers, or other forms of ambulatory care within the context of a large multi-level institution like Denver Health, and I'm sure Dr. Gabo would agree with that.
Thank you. To be a good example, my time is up, but I want to also, without objection, accept the chart from Blue Cross Blue Shield into the record that was brought to us by Dr. Burgess. Chair now recognizes Dr. Ginry for 5 minutes.
Madam Chair, thank you so much. I want to direct my first questioning to my colleague from Georgia, Gainesville, Georgia, and the president of the Medical Association of Georgia. Glad to see you, Dr. Williamson. And I have a series of questions that I would like to ask you. First off, do you support a government-run plan?
No, the Medical Association of Georgia does not support a public option or a government-run plan, in addition to the public plans that already exist, Medicare and Medicaid.
Right. We're talking about the government option plan that would be competing with the private insurance plans.
We do not support a public option.
What would a government-run health plan that I just described do to your ability and those of your colleagues to treat your patients? What do you fear the most about that type of a government-run option?
My biggest concern is that it, like Medicare, will become the only option. And I think over time, I think the plan as it's set up in the discussion draft already has the framework for that, for basically all private plans to have to conform to certain rules over time. And my fear, and I think it's a very real concern, is that over time, other plans will disappear and the public option will become the only option, and we'll be left with a single payer system, which I think if you look at what's happened across the planet, single payer systems basically save money by rationing care, and I see that as an inevitable consequence of the creation of a public option, no matter how benign it looks. at first glance.
Well, that was going to be my next question. You pretty much answered it. My question would be, Dr. Williamson, do you support a government-run health care system with the ability to ration care based on cost?
I absolutely do not support that. I think that care decisions should be made on an individual basis when the patient sits down in the physician's office, and I don't think that the government can substitute for the training that a physician has and the opportunity that a physician has to look the patient in the eye and decide what that patient needs.
Let's see. I'm going to skip over number 4. My fourth actually. We have heard testimony in this committee recently regarding the Massachusetts health care system and the fact that those with public health insurance in the state are twice as likely as those who choose private health insurance to be turned away from a desired physician. As a physician, practicing physician, what are your thoughts on the reasons behind that kind of disparity in access between a public and a private insurance plan?
Well, public plans in general, and I'm speaking in general now, are associated with quite a lot of paperwork. They're associated with the hand of government, and right now in Georgia we're looking at these recovery auditor contractors that are moving across the nation and coming back and recouping money, saying that you coded something wrong 20 years ago or 10 years ago, and coming after those dollars. These sorts of things that the federal government has the power to do makes dealing with them as a payer a very daunting prospect. And traditionally, government payers have been at the bottom of the barrel in terms of covering costs. And so physicians feel like they can't deliver to patients what they've been trained to do. And the downsides associated with the government as a payer are daunting. And, I recently had the opportunity to go to the AMA, and one of my colleagues from Massachusetts stood and spoke loudly in support of a national public option. But I believe that the folks from Massachusetts probably want a public option nationally so they don't have to pay for their own anymore.
Well, Doctor, I appreciate that response, and I absolutely, the reason I ask you the question, because what we're talking about here is something very, very similar to this Massachusetts model. And we have even heard suggestions from the majority that it may be that physicians who are treating people within this exchange would absolutely have to accept the public option plan, or they would be ruled ineligible to participate in Medicare or Medicaid. So they would have their arm twisted behind their back and have no choice. Which is pretty frightening. I've got just a little bit of time left, and I wanted to go to Dr. Ehrlich and also Dr. Gabot if we have a chance, time permits, Madam Chair. I hope you'll let me get this in. If health reform were to include a requirement that all Americans purchase health insurance, do you think that hospitals would need continued federal funding to offset cases of uncompensated or charity care, and why? And basically, I'm talking about DSH hospitals and the suggestion that we're going to save money by eliminating all DSH payments when we pass this bill.
Well, my sense is the answer to that is yes, you would still need to have some supplemental dollars rolling in, simply because the reality is that there still are things as bad debt, people who need care get it and then can't pay for it because of competing priorities of their own pocketbook, and plus the fact that we really haven't gotten to the point of having fair practice expense accountability within the remunerative system yet, and that is absolutely critical to any kind of a public plan. If we're going to go that way, then we have to have fair practice expenses covered before we can go forward.
That would be a pretty painful pay-for your
That
system.
is correct.
Dr. Gabot.
My understanding, Congressman, is that this bill does not cut disproportionate share payments, and I think that that will be necessary to be sustained, at least in the foreseeable future, because we know that many of the patients that we serve, the homeless, the chronically mentally ill, are traditionally difficult to enroll. And so I think if we got to full coverage, certainly we may be able to decrease it, but I doubt that it will ever go away. So we support the preservation of DSH as outlined in the draft bill.
You support the elimination of DSH payments? Is that what you said?
We support the maintenance of DSH payments.
Oh, absolutely. Yes. As I expected you would, Dr. Gabot, and as Dr. Ehrlich, and hospitals all across the 11th Congressional District of Georgia support the continuation of those DSH payments.
Thank
you for your patience, Madam Chair.
Thank you.
I yield back. Thank you.
The chair now recognizes Congresswoman Baldwin for 5 minutes.
Thank you, Madam Chairwoman. I want to welcome a fellow Wisconsinite, Dr. Ulrich. Pleased to have you on the panel. I wanted to probe into an area. I stepped out for a little while, so I don't know if anyone else has raised this, but in your testimony on page 7, you talk a little bit about care issues at the end of life and make some recommendations. And it's one of those very challenging topics, because we certainly hear from much research that much of our healthcare dollar goes to treat people at that stage of their lives. But that's one thing. I mean, much more disturbingly, that often doesn't align with the wishes of the person being treated. Could you elaborate a little bit more about both your recommendations to this committee in that arena, but also the practices at the Marshfield Clinic, what you have implemented in this regard?
Yes, thank you, Congresswoman. I appreciate the question. At Marshfield Clinic, we do have, in conjunction with St. Joseph's Hospital, who's our hospital partner, developed palliative care. We have palliative care fellowship, et cetera, where we train young physicians who are interested in that. We work with families, the patient, obviously, et cetera. Really try to do two things. One, there's a humanistic process that occurs under palliative care, and that's taking care of people in a comfortable surrounding in their last few weeks or days of life. And that really is a throwback, if you will, to the way medicine used to be practiced before we were very fancy with technology, et cetera. And it's not something that we should ever forget. It's something that we need to continue. So we are committed to doing that and will. And I think most medical organizations throughout the country would be in synchrony with that kind of concept. The question you raise about the cost of care at the end of life is obviously an important one. And if you think about the cost of medical care in our country, there are really two main things we need to understand. One, as you point out, the costs escalate rather dramatically as life is ebbing away from us, because it's an emotional decision for families and patients to keep mom or dad or grandma or grandpa alive for a little while longer, et cetera. It's very difficult for families to say it's time to say goodbye to someone. So we continue then to provide medical care under those very difficult circumstances. There's a cost to providing that care. The other thing that I would like the subcommittee to understand is that not all costs within the system are the same. So that we know from the Commonwealth Fund, for example, that really it's only about 20% of patients that are costing about 75 to 80% of care in this country. So that if we can manage these chronic illnesses, and in particular patients who have more than one or two chronic illnesses concomitantly, that's where the cost savings will come as we get better in managing folks with complicated chronic illnesses who concurrently are suffering from several of them at the same time.
Your testimony specifically points to things that we could do earlier in life to talk about having people think about advance directives or other documents. I would offer you to elaborate on that, but also I see some other nodding heads. If I would open this up to any of the panelists who would like to make a contribution on this point.
Thank you. What Dr. Ulrich just described is the value of primary care. It's having that relationship of trust with people over time in which you can have that type of dialogue. And I would say that those sorts of decisions are so important, so critical to the family as a whole, and many of those decisions can take place outside of a hospital in terms of where those final days and weeks are. In fact, I would submit that most people would like to have a very dignified death in the place where they can be surrounded by most of their loved ones. And so, again, we return right squarely back to what primary care brings to the system. It's what Dr. Ulrich said used to be part of medicine that's kind of gone now. We need to recreate that kind of system. It's in that system that savings are made, quality goes up, cost goes down.
Please, Dr. Wright.
Yes, I just would like to agree that what needs to take place and is often missing is the conversation, which begins with the relationship. So I completely agree and would support recognition of the value of the cognitive services. Not to say that folks who do procedures for a living are not thinking them, they certainly are, but the importance, I've seen it over and over in my practice, that while someone does indeed benefit from a procedure, what's wrapped around that procedure, the informed consent process, the education about the disease process, and right now the aftercare to try to prevent that from ever happening again is incredibly valuable to that individual and that family and our economy at this point.
Dr. White, did you have a comment?
Yes, I'd just like to add that I think, as Congresswoman Capps had mentioned earlier, that the patient advocate role that nurses provide is absolutely important in this. I think the emphasis on primary care medical home, nurse practitioners being involved in that who have the skills for those conversations, discussions, and the relationships, I think would be an important consideration for it all.
Thank you. I would like to briefly add, I think that resources spent on time with the doctor saves money in the long run. If you look at the percentage of medical expenditures, physicians' services constitute a small fraction of that. By concentrating on that, whether it be for primary care or for a specialist, you're going to save money in other areas, whether this is the end of life, very sick patients. So funds, resources that are concentrated on giving the patient or the patient's family face time with their doctor is going to save you lots of money across the system.
Thank you. The gentlelady's time has expired, and I now recognize Congresswoman Blackburn for 5 minutes.
Madam Chairman, and thank you to all of you. I want to do a yes and no and show of hands to get where you all are on some issues. And by the way, thank you for your patience with us today. As you know, we have another hearing that's been going on upstairs. Okay, show of hands. How many of you favor a single-payer system? Okay, nobody on the panel favors a single-payer system. Okay, how many of you favor a strategy, putting in place a strategy that would eventually move us to a single-payer system? So nobody favors doing that. That's really interesting because there are some of us that fully believe that this bill that is before us, whether it is the House version, the Senate version, or the Kennedy plan, would move us to a single-payer system. And we make that determination based on experience that we've had from pilot projects and from programs that have taken place in the states, my state of Tennessee being one of those. Okay, how many of you favor having government-controlled comparative research? Nobody favors government-controlled comparative research, okay? How many of you, okay, we've got some takers on that one. All right, just show of hands. The comparative research board that they are talking about having, that this bill would put in place, how many of you want to see that? Okay, so got Epperly, Ulrich, Wright, White, and Gabal. Okay. Dr. Hankins, all righty. And then how many of you favor having that comparative research board make medical decisions for patients? Nobody. Okay. All righty. Dr. Epperly, if I could come, you know, it makes it kind of a head scratcher to me, and I appreciate having your views on this because we know that the Comparative Research Results Board would end up making a lot of the medical decisions for patients, and it would move that away from the doctor-patient relationship. I wanted to ask you, you had mentioned in your testimony that you felt that a public plan would be actuarially sound. What I'd like for you to do is cite for me the research upon which you base that assessment and that decision. How did you arrive at that?
Yeah, I would say that I'm not aware of anything I said that it would be actuarially sound.
Well, I think that's a statement in your testimony.
What I will say as you look that up, though, is that we believe that expanding coverage to people and giving them choice is a sound decision for America in regards to helping people get health care coverage. We are in agreement with that. As it presently stands, this would have to be at an enhanced rate above Medicare. That's why we say that, you know, if the model is Medicare, that's not going to work. But at anything that starts to promote primary care as being a solution to that, that will work. And that's
okay, let me interrupt you at that then. You say that it would be at an enhanced model above the rate of Medicare. So, in other words, it's going to cost more.
Yes, but the...
Okay, now yesterday, if I may interrupt you again, Secretary Sebelius said yesterday that this would be deficit neutral. So I'm trying to figure out, and I asked her yesterday how she could say it was deficit neutral. We've not had one witness out of all the hearings we've done that has said they felt like this would be deficit neutral or would be a money saver. Everybody has said it's going to cost more.
I would say that it would be beyond deficit neutral in a positive way, because where the savings will come from the system is in regards to reduced hospitalizations, reduced readmissions, more
okay,
efficient
if I may interrupt you again, do you have any kind of model that shows that actually happens? Because you can look at TennCare in Tennessee, you can look at Massachusetts, and you can see that that does not happen.
Yes, Community Care of North Carolina proved that. Other international studies have proven that as well. That's why when we talk about the value of primary care, we're saying that there's system savings from across the existing system that will save the entire system money.
Okay. All right, but I can tell you that in Tennessee we found out that did not happen. And so I appreciate your input. Dr. Williamson, I've got 15 seconds left. Medicare patients, senior citizens, are just up in arms. They see that their care is going to be diminished somewhat, that savings from Medicare are going to go to pay for care for younger enrollees in this public plan. My seniors that are coming to me and saying, we are scared to death, what do I say to them? What is Medicare going to look like after this public plan goes in place?
I don't see anything in the draft, in the discussion draft, that gives me hope that we're moving in the right direction in terms of payment. I think that private contracting and empowering patients to buy their own health care, I don't think we should ever take away a patient's right to pay for their own health care. And if we do that, we're committing a colossal mistake.
Okay, thank you. I yield back.
Thank you. Chair now recognizes Congresswoman Harman for 5 minutes.
I thank you, Dr. Christensen, and point out that our committee benefits a lot from the fact that many members are medical doctors and nurses and have extensive medical backgrounds. I hope the panel is impressed that we actually, some of us, others here, know a great deal about this. In my case, I don't have either of those, but I am the daughter of a general practitioner who actually made house calls to 3 generations of patients before he retired in Los Angeles, and I am the sister of an oncologist, a hematologist, who was the head of that practice at Kaiser in San Rafael, California, before he semi-retired. He's younger than I am, so go figure. But he did win the Healer of the Year award in Marin County for his compassionate treatment of patients. So I love listening to a bunch of docs and experts who put that on the front burner. I come from Los Angeles County, as you just heard. We are extremely concerned, if not panicked, about the president's proposed cuts in dish payments. Listening to this panel and listening to you, is it Dr. Gabot? Or yes. And reading your excellent testimony, I think your bottom line is you don't want cuts on the front end. You want to see how all this works and phase in cuts later once the efficiencies take hold. Is that what you are saying?
That's correct.
Thank you. And on this point, Madam Chair, I would like permission to put a letter in the record from the Board of Supervisors of the County of Los Angeles.
Without objection, it'll be admitted to the record.
Thank you. Well, I would just like to invite the panel on this subject to address, and starting with you, Dr. Gabot, and it seems like you may have a bit of laryngitis, am I right?
Congresswoman, I have a chronic voice problem.
Oh, my goodness.
Called spastic dysphonia, and the treatment for it is Botox, but it doesn't do anything for my wrinkles.
as my kids would say, I think that's more information than we need. But I, I appreciate this. I hope I'm not stressing you, but I would really like the record to be more complete on this subject because I think it is an urgent subject for at least our large metropolitan areas, and one this committee has to take very seriously. And based on the comments I heard from the minority side, I think everyone here generally agrees about this. Yes.
Congresswoman, I think all of the safety net institutions would be very concerned if disproportionate share funding were cut at the front end of this process. We rely heavily on disproportionate share funding to cover not only our uninsured patients, but also the gap between what Medicaid pays us and our costs. So I think that timing on this issue is really critical. And as I said earlier, I think what we've learned from the expansions in the past of Medicaid and S-CHIP is that it takes a long time to enroll certain highly vulnerable populations. They're vulnerable in so many ways that enrollment is not an easy process. So it's going to take a period of time to really get to full coverage, even with this bill. So I don't think we can cut DISH at the front.
I realize I only have 48 seconds left, so let me just expand the question in case anyone else wants to answer it as well. One of my personal issues, since I focus on Homeland Security issues generally, is surge capacity in our hospitals in the event of a terror attack or a large natural disaster. And so my question is, what is the relationship between the ability of our level 1 trauma centers, which are located in many of our DISH hospitals? What is the relationship between the ability of our level 1 trauma centers to be available in the event of a terror attack or a natural disaster and the proposed cuts in DISH?
Congresswoman, I think you're right that these are related in that many of the trauma centers are at the disproportionate share hospitals, and also many of the pre-hospital care services and burn units, so that much that you would need in disaster are located in these safety net institutions. So they need to be preserved, and you can't destabilize them financially at the beginning of the process and still preserve those critical resources.
Thank you very much.
Thank you. The chair now recognizes Mr. Pitts for 5 minutes.
Thank you, Madam Chairman. Dr. Ulrich, if a large number of private payer patients were to shift into the public plan, and the public plan is paid based on Medicare rates, what would be the effect on your ability to continue to offer the same level of services that you provide today?
Well, it would be impacted extremely negatively and probably fairly rapidly. It would be beyond my capacity to give you an exact time frame, but it would be disastrous, I think, is a fair word to use.
Now, are you treating a large number of Medicare or Medicaid eligible patients in your part of Wisconsin?
Absolutely. If I can enlarge on that just a second, there already is a problem as you're describing. In certain parts of the service area that we provide, we comprise about 33% of the physicians. We are caring, however, for 70% of what we call fixed payer, which is Medicare and Medicaid patients. Why? Because other providers are not choosing to take care of those patients. So this is already happening. This is
so how are you surviving now if you...
Well, you know, we try to watch our costs as closely as we can. I've found it necessary to try to branch into ancillary revenue streams, try to sell the electronic medical record. We do food safety with Cargill, with Hormel, et cetera, because I'm not confident that just providing health care is going to be a way to sustain our organization.
Dr. Williamson, each year fewer and fewer physicians are willing to accept Medicare and Medicaid patients. From your perspective as a practicing physician, could you tell us why you think this is?
I think, as has been said, it's becoming more and more impractical to do that. I think inertia plays a large role here. Doctors have done it for a long time. It's becoming less and less practical because the Medicare and the Medicaid payment systems have not kept pace with the cost of providing care. And physicians want to keep taking care of these patients. We want to keep doing that. And so what you're seeing across the nation are doctors basically doing the very best they can to control costs and keep functioning in this environment. But as I said, it's a house of cards. Some doctors are retiring early. They're getting out of medicine. They're going into other ancillary revenue streams because these payment systems simply are not adequate to cover the cost of providing care. And moving more patients onto those types of payment schedules is going to adversely impact everybody's health care in this country, not just those patients that are enrolled in the public option.
Now, if we allowed more people to purchase health care services with untaxed dollars instead of relying so heavily on third-party payers for routine health care services, do you think that we could solve many of our problems faced today by consumers or providers of health care services?
Congressman, I think you just hit the nail on the head. Right now, what we're trying to do is solve a problem for uninsured patients. That's what all this is about. We wouldn't be sitting here if we weren't dealing with this issue. I think that by making it feasible for every person to own and control their own insurance policy is the way to solve this problem. And I know that we can do that with the tax system. With tax credits, tax subsidies, we can put the control back into the hands of the patients so that the government doesn't have to orchestrate this massive machine that we're looking at right now that's going to not attend adequately to the needs of the individual patient. I believe by restructuring the tax system, we can take care of the uninsured patients, and we can solve this problem without putting private insurance companies out of business and taking away the ability of individuals to purchase their own health care.
Dr. Wright, if you could respond. Polling has suggested that over 95% of the American people support the right to know the price of health care services before they go in for treatment. What do you view as the major barriers to the American people getting the price and quality information that they want and they need?
I think there has just not been enough transparency in the pricing structures. It's Byzantine at the very least. It's difficult to figure out even within a practice. Often most of us have no idea what an individual patient is paying for a service. So I think the system would clearly benefit from additional transparency.
And how would the patients, the providers, the taxpayers benefit by public disclosure of price and risk-adjusted quality?
Well, I think it lends to it's one component of their decision-making process. I would not uncouple pricing information from quality information because cheap care may not necessarily be the best care. On the other hand, the best care can be less expensive than we're delivering it now.
What about the agency that reports price and risk-adjusted quality information to be completely separate from Department of Health and Human Services? Do you see any conflicts of interest with HHS reporting on their own programs?
No, I don't.
Okay, my time's up. Thank you very much, Madam Chair.
Thank you, Mr. Pitts. Chair now recognizes Mr. Gordon for 5 minutes.
Thank you, Madam Chair. Last week, the President put forth a challenge to find ways to reduce the number of medical liability suits without capping malpractice awards. I agree with the President. I think if you're going to be able to try to reduce the cost of health care, you've got to get all the inefficiencies out, and this is certainly one area. PricewaterhouseCoopers estimate there's $280 billion spent in defensive medicine. We can't wrench all that out, but surely there's some savings that can be made there. That's why I'm drafting medical malpractice reform alternative legislation responding to the President's challenge. The bill encourages states to step outside the box and test so-called alternatives like health courts and methods. It also I think that this will help lower the cost of defensive medicine. I think it will compensate patients faster and be more fair. In my home state of Tennessee, we enacted a certificate of merit requirement last October that has already proven that there's been a 4% reduction in malpractice premiums. Earlier, you were all asked about whether you would think that malpractice reform should be a part of the overall reform, and you agreed. So I want to quickly ask you to say why and what savings you think we might be able to achieve. And Dr. Eberly, why don't we start with you?
First, I applaud you for doing this. I think it's the right step in the right direction.
Don't applaud me. Let's just move on and tell me why it's good. No. Tell me why. Please tell me why it's good.
Oh, okay. I think it's the step in the right direction. If there is not a relationship with patients, the default is to do more to patients, not less, so that you cover yourself. That's why the relationship is critical. If we don't get reform in place, then people that don't have that relationship will continue to order every test known to man to try to diagnose the problem.
I agree completely. I think the costs are hidden, but they are very, very real, and I think they're gigantic. Physicians order expensive tests to rule out conditions that they don't suspect but might occur randomly in one in several thousand. And if someone gets $10 million from a lawsuit and it occurs in an incidence of 1 in 10,000, if you don't screen for that, you're statistically going to lose money. And so you're exactly on target here. We must have real medical liability reform. I will tell you, in Georgia, in 2005, we enacted a very effective tort package. The number of suits in Georgia are down by 40% now. We only had 3 professional liability carriers in Georgia. We now have something like in the teens. And we have a cap on non-economic damages, not total damages, but only non-economic damages, so that economic
We're not talking about caps here. We're thinking about things less than that. Dr. Ehrlich?
I would agree that what both gentlemen before me said. The reality is that, having to pay some dollars out in those unfortunate circumstances is an actual cost, and without some relief from that, we will continue to bear those costs.
Dr. Wright?
I also agree. I think the burden of this is quite large, and I particularly like the idea that you would test various options, various approaches to controlling the tort problem.
Yeah, what we want to do is give incentives for states to experiment, and let's find out what might work. Dr. White?
The American Nurses Association does have some concerns about caps, and they have a position statement.
Again, we're not
that they
talking
can
about
make.
caps. I said practices short of caps.
Caps. Okay, well, they have a position statement that they can make available to the committee.
But they would support malpractice reform short of caps. You raised your hand earlier.
Yes, yes. I mean, it's
Dr. Gabo.
As a governmental entity, we have governmental immunity, but in the broader discussion, I think that it's very important to do malpractice reform, and I think your idea of experimenting with health courts is a very good one.
Mr. Hawkins, earlier you said you weren't personally affected, but that's not the question. It's for the system as overall.
Yeah, and as a matter of fact, if I can, one important thing that a couple of members of the committee here have sponsored legislation to extend the Federal Tort Claims Act, FTCA coverage, that health center clinicians get today to clinicians who volunteer at health centers.
Well, that'll be part of the bill in terms of emergency rooms. I think they should be considered as first responders.
I would just say we know for a fact.
And Mr. Yarwood. Oh, I'm sorry. Okay, I'm sorry. You're saying you know for a fact that it helps.
That many local physicians and clinicians would volunteer time at a health center if this issue were addressed.
Mr. Roberts.
I think from pharmacy's perspective, it's not as large an issue, but still we would be supportive.
Mr. Yarwood.
It's a huge issue. We've talked about this before, and include us.
Ms. Fox.
We absolutely agree.
And let me, if I could go back, since we have a little more time, concerning those individuals that have the hospitals, are you finding it a problem now to get specialists to come into the emergency room because of the medical malpractice problem? Yes, ma'am, go ahead.
Because of medical malpractice, we aren't, because we have governmental immunity and our physicians are employed. So we have no problem getting coverage, and we don't pay extra for that coverage.
But it's because they're already covered. Yes. Okay, my time is up, and I thank you for your advice.
The chair now recognizes Mr. Shattuck for questions.
Thank you, Madam Chair. Dr. Wright, I want to begin with you. I also want to follow up with Dr. Ulrich because he mentioned a word that I think is very important. He talked about the incentives in the current policy or healthcare system. Under the tax code in America today, businesses can buy health insurance tax-free. Individuals have to buy it with after-tax dollars, making it at least 30% more expensive. You were just asked, and I want to follow up by a question by Mr. Pitts about transparency. I guess my concern about transparency is that until we enable consumers, individual people, to buy health insurance on the same tax-free basis that businesses can do it, I don't see how a consumer has the motivation to look at transparency. That is to say, if my employer provides me with health care and he or she pays for it, I don't see what the motivation is for me to go research the cost of a particular procedure at one hospital versus another, or one doctor for another, or the quality outcomes. Because I agree with you, I think that both cost and quality are things consumers want to know, but only if they're a part of a marketplace where those factors can make a difference to them. Would you agree?
I'm not a pricing expert. I'm barely a quality of care expert. So I understand your point. I am greatly concerned about the number of people who are not covered at this point in time.
Me too.
I know you are. And so I guess most of my priority in terms of getting this fixed has been directed at them.
Dr. Ulrich, is that one of the incentives that concerns you?
Yes, certainly. And if I can expand on that just briefly.
Please.
If we look at the quality equation, that's the outcomes of patient care and the patient-physician and the patient-physician interaction being the numerator, cost being the denominator, quality being the end product of that. The concern I have is this, is that currently we don't pay for that. We absolutely need to move to that model. But what hinders us now is the fact that patients don't understand necessarily what quality is. We did some market research, and what patients tell us is that, look, you guys are all the same. You all went to medical school, you all did residencies, so there's really very little to pick between you. When in fact, for those of us that work in the industry, there are differences. So the question before us is, how do we now educate our patients so that they can make fully informed decisions relative to that quality equation?
Dr. Williamson, I think if I gather your testimony correctly, you think that's exactly the point. If we empowered or allowed, just permitted, people to buy their own health insurance policy and therefore to shop for it and to be involved in the selection of the plan and the selection of the doctor, they would be motivated to use transparency, cost data, quality data, and make the market much more competitive, bringing down cost and causing quality to go up?
Absolutely, and I think it would raise quality on two levels. It would raise quality on the national level in terms of saving money in the entire system, and it would raise the quality that the individual patient perceives. Even though patients may not be able to judge scientific quality, they do vote with their feet. And I think if we had transparency, I think doctors are going to have to compete with each other. And if we can do what you have suggested, which is to empower patients to buy with the same tax advantage that employers have now, their own health insurance policies, and control that, then they control their medical decision making. That's the best way to keep costs down and ensure good patient care.
The health care policy I have advocated says that we should tell every American that has employer-provided health care that they can keep it and they can keep the exclusion. But every American that doesn't have employer-provided health care would get a tax credit. Those Americans who can't afford to buy their own health care would get a refundable and advanceable tax credit to go out in the market and buy what they want. We would then bring consumer choice to the entire healthcare industry. I'd like every member of the panel to tell me what other thing in our society somebody else buys for us. I mean, I struggle with this question, and I don't understand it. Our employers buy our health care insurance. They don't buy our auto insurance. They don't buy our homeowners insurance. They don't buy our suits. I don't buy my employees lunch. But why in healthcare do we decide that only employers can buy it? Is there something else that somebody on the panel can remember or can think of that is of that dimension, where your employer buys it for you and you're just kind of a pawn in the whole system? Dr. Williams?
I can't answer the question, but I can tell you where it came from, and it came from the notion of pooling risk. Patients realized that if I get really sick, I'm going to need a lot of money. And so they went together and they pooled their money, and then what happened is, over time, they've lost control of that pool of money. And that's where all this is coming from. Patients have turned over to others the ability to make their health care decisions for them by allowing them to pay for it.
So if we empower them to be able to buy their own health care if they choose it from their employer or out in the market, and we empower poor people to do that who can't afford it by giving them a refundable tax credit, we would also need to create new pooling mechanisms, would we not?
I completely agree with you.
Thank you very much.
Thank you very much, and I'll turn to Mr. Green for his questions. And I'll just say probably this is our last series of questions because the vote has been called, and your panel can be excused. You really, you really set a record for endurance. I'll have to thank you, each of you.
Madam Chairman, some of us were here last night at 7 o'clock. Well, you were too, I think, and we realized it started at 9:30 yesterday morning and finished sometime after 7.
Be thankful you weren't on that last panel.
Yeah, thank you. You'll at least get out before dark. Mr. Hawkins, as you know, I've been working with Representative Tim Murphy since we reauthorized Community Health Centers program last year on a bill we introduced, the Family Health Care Accessibility Act of 2009. The bill would extend Federal Tort Claims Act coverage to volunteers by deeming these volunteer practitioners at health centers as employees of the federal government. These volunteers would have to be licensed physician or licensed clinical psychologist and unpaid in order to qualify. This seems like an easy solution to the lack of primary care physicians in some areas, especially in medically underserved areas where community health centers are located. Yesterday, the GAO released a report stating that the lack of Federal Tort Claims Act coverage for volunteer practitioners can be a barrier for volunteers who wish to dedicate their time at a federally qualified health center. Can you elaborate on how the extension of the FTCA coverage to licensed physicians or other licensed practitioners would help increase the number of volunteers at federally qualified health centers?
Sure, Mr. Green, and thank you for raising that issue. In fact, just a couple of minutes ago, we were discussing the issue of malpractice, and I
hope my colleague, Congressman Murphy, was bringing it up.
That's okay. I specifically alluded to this legislation, which you and Mr. Murphy have collaborated on in the past and continue to collaborate on. I can't tell you, not only for primary care, Mr. Green, but even for urologists, dermatologists, you know, the biggest frustration that health center clinicians, who are virtually all primary care today, express is the barriers and difficulty they face getting specialty care, diagnostics, even hospital admits for the 7.5 million uninsured people we serve, in particular, not exclusively, but in particular. Allowing FTCA coverage to extend to individuals who, as you note, come into the health center and donate their time, do not charge the patient, don't charge the health center, would be a phenomenal benefit and boon, and would provide for much more fully integrated care and better health outcomes.
And we discovered this problem in Texas with Hurricane Katrina with all the evacuees. In our federally qualified health centers, we had medical professionals who couldn't volunteer in Texas because they weren't covered. So, and we realize now that that's a way we can provide for our federally qualified health centers. The discussion draft also addresses the issue of residency training in off-site locations like FQHCs, but it still allocates the funds to the hospitals and not to the off-site locations. Do you believe language in the draft should make it easier for federally qualified health centers and other off-site residency training programs to start up and operate residency programs? And again, we have an example in my district of a federally qualified health center has a partnership with Baylor College of Medicine in Houston, and they do it. And what I'd like to do is see if we can get a number of medical schools, because I want primary care physicians to know they can make a living at a federally qualified health center in a community-based setting. So.
Not only that, Mr. Green, but I'm honored to be part of a panel today that includes Denver Health, the community health center, as well as a public hospital.
Congresswoman DeGette has preached to me for years about Denver.
All the joys and the great work that Dr. Gabeau has done. Also, residency training program, Marshfield Clinic, which has a community health center embedded in it, doing residency training. And Ted Epperly, Dr. Epperly, whose family medicine residency training program in Boise, Idaho, is also a federally qualified health center. Perfect examples. Now, all are working locally with their medical schools and with teaching hospitals to ensure, because those residents, even family medicine, have to have a med-surg residency inpatient-based, so it can't be done independently. At the same time, the vast bulk of family medicine residency training, pediatric residency training, even general internal medicine residency training can be done in an ambulatory care site. More than 300 health centers today across the country are engaged in residency training programs. They have rotations of residents through them, and everyone's willing to step up and do more. All that's needed is the resources to be able to do so.
And if we know we need a chronic need for primary care doctors, then this is a way we can do that and hopefully expand it. One last question in my last 6 seconds. Discussion draft includes additional funding through the Public Health Investment Fund. And as many on the committee know, we've been asking for additional funds for federally qualified health clinics for years. How do you intend to use the new funds when you provide more services like dental and mental health? And will it also help build more FQHCs, because we know we need that in our country?
I think there are 2 or 3 quick points to make on that. Just last month, the Government Accountability Office, GAO, issued a report that pointed out that almost half of federally designated medically underserved areas in this country have no health centers, not a one. There are 60 million people out there today across this country, some of whom have insurance, and yet do not have a regular source of preventive and primary care. No family doctor, no medical or health care home. So the need is great. It runs in tandem with the extension of coverage that this bill would provide, but takes it that one step further, turning the promise of coverage into the reality of care through providing a health care home. The expansion of coverage to serve more people, as you noted, very importantly, the expansion of medical care to include oral health and mental health services, so crucially important. All of that will be afforded through the new resources in this bill.
And now, thank you again to the panelists, and we are in recess for the next panel to begin after this series of votes. It's 8 votes, but after the first one, apparently it's 2 minutes per vote, so it should go fairly quickly, hopefully. Thank you very much.